All right, awesome. Yeah. So week 3 already, it's too soon. Okay. So basically I'll be covering a big chunk of this session today. All of the anatomy of the GIT pretty much. Obviously can't go into too much detail and you don't need to anyway for year 2. In year 2, you focus on like a broad understanding of GIT, which is really good. I actually enjoyed GIT the most last year. So anatomy, great. So I compiled a massive list here. This is just a very brief, just a list of things that we studied last year. So if you're lost for where to start, you can just have a look at this and just go down the list pretty much. A few of these, especially the ones in the brackets, we only just touched on, but they don't really examine you on it. So just have a good understanding of what it is. If you guys have any questions or have no idea what some of these are, just chuck it into the text or DM me. So just chuck in a comment or something and I can just explain it. But otherwise, yeah, just use this as a list to work down when you study. Okay, so instructions for use. I don't know why I did this. Pretty much make sure that you learn GIT as a system. So don't just cram one thing at a time. Usually it'd be nice to actually try to link everything together. So physiology with the anatomy and then physiology with, I don't know, pharm. Okay, so really much easier if you work together as a system. And I just checked some resources here. And then I have a B in terms, whenever there is buzzwords involved, and then a red flag if there is high yield content. So pay extra attention to those red flags. All right, moving on. Okay, awesome. Freaking hate this. So there's 9 abdo regions. These are actually really, really important. You'll see when in year 3, when you go into a gastro ward, that this actually does a lot of the diagnostic stuff. It really gives you a lot of information. So if the pain, the location of the pain, where it moves, what kind of pain it is, it's really important. So get a good, be sound. So with this understanding of where, what anatomy lies underneath the abdominal wall. So obviously on the right side, usually, most commonly it'll be a gallbladder problem, and it could be a liver problem as well. In the middle, so the epigastric region, you've got stomach, you've got esophageal problems as well. And then less commonly pancreatic problems. So pancreatitis or something like that. And then left, not much, not very uncommon. But if that were to happen, then you would think about the spleen. And then right lumbar region, or the loin, okay, that part is usually just the ascending colon, right? So there's not much there other than the right kidney and the back. Here, umbilical region, usually think of appendicitis, if anything. So appendicitis starts as a vague pain in the central area, and then it moves and migrates to the right. And that's all to do with the embryology, which we'll talk about briefly later. Okay, but obviously there is a lot of intestines over there as well. So check that out. Here you've got descending colon and then sigmoid. So think about things like IBD. Okay. Yeah. And then obviously here, appendix. Now in real life, appendicitis and gallbladder problems are the most common. Literally you'll see them everywhere, every day. But here, there's also the 4 quadrants. If you're lazy and you don't want to use the 9 quadrants, you can go and just resort to the 4 quadrants. They're a bit more vague. But yes, you need to know both of these slides. Okay. So here, I'm not going to go through all of it, it's too long, but again, this is extremely important, especially when it comes to a clinical setting or for OSCEs, because the character of the pain is always really stereotypical, especially in exams and OSCEs. Obviously, there will be exceptions everywhere in real life, but if you see these buzzwords, then you know immediately, oh, it's cholecystitis. Okay, so right upper quadrant pain, usually there's positive Murphy sign, which means that either when you press down on it, the patient will actually stop breathing because it really hurts. So they'll go like that. And then, and that is positive Murphy's. And sometimes you can have cross tenderness, positive Murphy's, which means that when you press down on the other side, it also hurts and they stop breathing. So cholecystitis on the right, you've got colicky pain. So colicky meaning it comes on and off. And if it's colicky, usually that's characteristic of a stone. So anything that ends with lithiasis means that it is a stone. So there's pyelolithiasis, which means that it's a kidney stone. This is a cholelithiasis, which means it's a gallbladder stone. So biliary colic is just basically talking about this colicky pain. It's like a symptom, but they talk about it as if it's like a condition. And it just means it's a problem with the gallbladder and the gallstones. So yeah, colicky pain after meals. And it's worse after meals because that's when your gallbladder needs to squeeze, right? So when you eat like a fatty meal, for instance, then the gallbladder needs to squeeze the bile out so that the bile can break down that fat. But obviously when it squeezes, those gallstones will come and block the duct and really hurt you because it's starting to block and it's starting to like push on the wall of the gallbladder. Retrosternal epigastric pain, really, really stereotypic GORD. And it worsens when you're lying down or after eating a big meal because the stomach acid goes up your esophagus and it hurts. And usually it comes with like a weird tasting pain, weird taste in your mouth as well. As some people get other weird ones like palpitations, but that's less common. Vague pain in central umbilical region, which is central and moving down to the right iliac fossa, that is appendicitis, like 100%. If there is like, in your exams, if you hear those words, appendicitis. Loin to groin pain, always, they give this like builder on a hot day kind of thing, that is renal colic. Reason why it's like builder on a hot day is because apparently, like, I think this, I'm not sure, like the stones will more likely lodge on a hot day. David, do you know why? I think maybe they form better on a hot day. I'm not sure. But yeah, usually that's the stereotype. And then radiating to the back, central pain, it's either pancreatitis or aortic dissection, but usually aortic dissection is a lot more painful. And you hear the words tearing. Yeah, that's obviously when the aorta, the abdominal aorta kind of tears. Okay, usually to the region between the two scapula. And then rebound tenderness, this I saw for like in real life for the first time. I thought it was like a joke, like how come people would feel pain when you lift off? That's so weird. But I did it yesterday in a appendicitis, not yesterday, the day before, appendicitis patient. I pressed down and then I lift it up. You always have to ask, oh, does it hurt after I lift or does it hurt when I press, right? Rebound tenderness is when it hurts more when you lift it. Okay, so it's like a recoil, rebound, same thing, I don't know. And then basically means peritonism, okay? So usually you can have peritonism. Peritonism is a symptom, not a condition. So peritonism is like the aggravation or irritation of the peritoneum. And it can happen in appendicitis because obviously it's inflammation in that area. It can irritate surrounding things like the peritoneum. But peritonitis is the inflammation of the peritoneum. So that's the condition. And usually that is very diffuse pain. So you'll have rebound tenderness everywhere. Okay, and then painless right upper quadrant mass, pretty bad. Always think cancer, pancreatic cancer until it's proven otherwise. Suprapubic pain, dysuria, burning pee, okay, and then fever, always UTI. Pretty nice. Let's move on. That was way too much time already. Clinical signs, go through them. You always use things like, what's it called? Tally O'Connor. Okay, so those explain these very well. But very quickly, Robson's is for appendicitis. So you press on the left and it actually causes pain on the right at your McPerney's point. And then you've got the Murphy sign, which I talked about already. So you press down and it hurts to breathe. So they stop breathing. I don't know how to say that, so I'm not going to say it. Painless jaundice, right upper quadrant mass. So usually it could be like something blocking the pancreas. Oh, blocking the bile. Yeah. So not good. All right.
I think you should say that for educational purposes. I think you should at least try.
Try to say what? Okay.
Yeah.
Crevasses.
Smashed it.
I can't say it.
We're all smarter as a result. Go again.
Oh, come on, man. Don't do that.
Okay.
I still don't know
You don't
how
have
to
to
say.
do it. You don't have to.
Crevasses. Okay. Move on. I'm butchering that. Okay. These bruising means pretty much retroperitoneal bleeding. So I think C shape for Edward Cullen. And I don't know why I think that, but yeah, that's how I remember it. And then Gray Turner's sign, which is on the flanks, which is on the sides. Okay. And those are just perfect signs of acute pancreatitis. Okay, cool. Moving on, abdominal wall. Now, this is actually a red flag because it took me forever to remember it, but it does come up. So, and when you learn this, learn also what, I don't know which slide it is on, but we'll come to it later. It's basically like learn also the what layers it becomes in the scrotum. So during the descent of the testes, the skin will turn into something like campus fascia and then so on. Okay, so learn it as together, be great. So yeah, this, like, what can I say? External oblique, internal oblique, transversus abdominis, and then transversalis fascia. Yeah, okay, just memorize this. Okay. Next one. So here are the actual muscles that I just talked about. So remember the fibers. Okay. So hands in pockets means the fibers kind of going downwards. Looks like I'm raving or something. And then hands across the chest this way. And then wrapped around the body like glad wrap. This one's transversus abdominis. And then there's the rectus abdominis. Okay. So just know what they are. You don't really get asked much about them. Pyramidalis is at the bottom. Literally don't bother, like never comes up. Okay, next one. Innervation. So there's this kind of innervation, dermatomal innervation. So think shingles sometimes. When it's shingles, just remember that like it spreads across a dermatome. So if you see like a rash that goes across only one bit or like across one side, it really suggests that it's to do with like T6, for instance. Okay. So yeah. So T7 to T12 are the main roots that kind of innervate the abdominal wall. There is also L1 that does the inguinal region. Remember T10 is the umbilicus. Okay, that level. Cool. Next one. So I forgot to do this. So that's why I just chucked in pictures, but that's pretty much how I learned them as well, just looking at textbooks. Just remember what the names are and where they are. Musculophrenic over here, and then it turns into superior epigastric and then inferior epigastric. And then we've got the deep circumflex and then the superficial circumflex here. Yeah, so pretty much I'd suggest going to Gray's for this, or Nettis. Yeah, musculophrenic innervates this region here, and then the rectus muscles, rectus abdominis, they are innervated by pretty much both the inferior and the superior epigastrics. Would you say this is high yield? I don't think so. Just remember where they are pretty much. Okay. And same for the venous drainage. There's a superficial and there's a deeper one. Just remember where they go. And you can pretty much figure out what they drain from that. Okay. All right. Ooh, that's a very pixelated picture. I just wanted to show that the rectus sheath is here and it's pretty much underneath the external and then next to the internal. Okay, so Cool. There is a rectus sheath on top of it, where the external muscle is. So this is important. The arcuate line is like 1/3 underneath the umbilicus. So 1/3 of the way from the umbilicus to the pubis. So that's where it is. Okay. And this really confused me when I learned it, but basically the rectus sheath, the sheaths actually change when it gets to the arcuate line. So here above the arcuate line, you've got the aponeurosis of the transversus abdominis muscle, as well as part of the half of the aponeurosis of the internal oblique. They actually go behind the rectus muscles. But then when it comes to the arcuate line, they all go in front. So just remember that. Yeah. So that's a transition point in the rectus sheath. Same thing again. Okay, descent of the testes. So they love asking about stuff like this. But basically, familiarize yourself with the vasculature for the testes, because it can kind of explain some of the conditions. For instance, you've got the nutcracker syndrome, which we'll talk about later. But yeah, just familiarize yourself. There is obviously these 3 arteries going into the inguinal ring and then into the scrotum. So there's the testicular artery, cremasteric, and the deferential, or the artery to the vas deferens. Okay. All 3 of them, they arise from different regions. So I've written them here. And yeah, they all go into the scrotum. Now here, the testes are drained by the pampiniform plexus, and then they go up, and then into the external and internal external pudendal vein. Okay, so yeah, just know of them. And then here we are, the difference between testes and scrotal innervation is that the testes are innervated by the renal and aortic plexi, and then which becomes the testicular plexus. And then whereas the scrotum is more superficial than an innervation. So I have a picture of it later, but the anterior 1/3, they are innervated by these nerves that originate from ilioinguinal and genitofemoral branch of the genitofemoral nerve. And then there's the posterior 2/3, which is basically the pudendal nerve that turns into the posterior scrotal. Okay, lymphatic drainage is more important to know, because they kind of want you to know that the testicular cancer actually manifests as this, as the palpable Virchow's node. So that's the Toisier's sign. So usually in the left supraclavicular node, you would feel for it. And if it is palpable, that could indicate more of a cancer kind of thing, because usually gastric cancer will go there, and then it will enlarge the lymph node up there. And that's all due to the fact that it flows to the para-aortic lymph nodes, and then it goes and affects that lymph node first. Okay, so that's why it's a sentinel lymph node. Whereas the scrotum, it's drained by more superficial lymph nodes. Don't really need to know so much, but yeah, here they are. Okay, so PP. I was a bit bored. So the 2 big ones that they want you to know are varicocele and testicular torsion. Lots of buzzwords here, but pretty much bag of worms sign is basically when the testis is like kind of like on a 90-degree angle and twisted pretty much, and it just, actually no, that's torsion. The bag of worms is like when the scrotum kind of looks really like bumpy. Okay, and the nutcracker syndrome is basically when the SMA kind of because the SMA goes on top of the left renal vein, sorry, and so pretty much it just compresses it and puts pressure on it, and then it causes buildup of that blood there and varicose vein. And because of that buildup in the pressure, it actually travels downwards on the testicular vein, and then causes a problem in the testes as well. So nutcracker syndrome is this problem. Okay. Bag of worms, buzzword. Testicular torsion usually comes in with like pretty bad signs. It's pretty urgent and it seems urgent. So it's like 10 out of 10 pain in one testes. And that's pretty much a medical emergency, because otherwise you have to like get rid of that testes, because like it can start, becoming ischemic and dying. Okay. All right. This is important. So like I said, learn the abdominal wall and then learn what it turns into. So the scarpus fascia, okay, it actually then turns into the dartos muscle, fascia, sorry. And then the one underneath, so the campus subcutaneous fat, pretty much, and fascia, it will turn into the dartos muscle. External obliques, external spermatic, that's pretty easy. However, just remember it doesn't get easy after that. So the internal oblique then turns into the cremaster muscle, and then the transversus abdominis doesn't get caught. So it actually stays and it doesn't go down into the scrotum, whereas the transversalis fascia does. Okay, so just kind of think, the two ones with the T's, they are interesting ones. So the first one, the TA doesn't go down. Then the transversalis fascia, that's the one that kind of goes around the spermatic cord. That's the one that surrounds the spermatic cord. Okay, so yep. And then you've got the peritoneum, so the parietal, and then the visceral peritoneum. It comes and it turns into the tunica vaginalis, and that's often where we have that problem with the inguinal hernias as well. Give me one moment. So let's see. Yeah, ugly photo of the two viscera, parietal and visceral peritoneum that goes down into the testes. Okay, cool. All right, so you need to know the contents of the spermatic cord pretty well. Usually because I'll say something like, oh, so you were going to repair this inguinal hernia and then, snip the wrong thing. And so what gets affected? So you need to know the nerves inside pretty well. And you need to know their distribution. So what do they actually, what parts of the skin do they innervate, for instance, okay? So you've got the inside, you've got these things. Let's move on. So okay, well, I put it in the wrong place, but you've got the ilio. How do I go back? Why am I such a boomer?
So I find like the back button generally helps with that.
Oh, it worked. Okay, because I've been pressing it and I
I'm just
didn't do
kidding.
that. Okay.
I'm really unfair.
Yeah, so that's the spermatic cord here, and then in females it is round ligament. You've got the vas deferens, you've got the artery to vas deferens, you've got the like all of this stuff. Like, I don't think that me reading it out to you will help you, but just remember it. Okay, so this is where the distribution of those like genital region nerves are. So the iliohypogastric is over here, and it actually goes and innervates this part and this part. So the upper inguinal, and then there's the hypogastric here. And then also the muscles. So that's M for like muscle innervation. This is a sensory, S for sensory. So ilioinguinal, it does most of the genitals, but also this part as well, okay, of the thigh. And then the genital branch of the genital femoral nerve, which is also in the, goes into the scrotum as well. It innervates like the scrotum, okay? So just to remember, the genital branch is inside the spermatic cord. The ilioinguinal nerve, which is the one that's most commonly affected in surgery, is outside. So outside of the spermatic cord, it does travel with it down in through the inguinal canal, but it doesn't actually go inside the spermatic cord. And the other day, actually, I had this a hernia patient. Oh no, not a hernia patient. He came in with like pain running down the medial thigh, as well as like on top of his like genital region, and he'd been like suffering for a long time, and they kind of diagnosed him with a tendonitis of the, so basically the abdominal muscles, the tendonitis of the abdominal muscles kind of compress this nerve, causing that pain. Yeah, pretty cool. Okay. These are some memory tools for how to remember what's inside the spermatic cord, but just remember there is the L1, L1 ilioinguinal nerve on the outside as well. Okay, this is the inguinal canal. So it starts from the transversus versalis fascia, and it moves down. So you just call this the deep inguinal ring, the superficial inguinal ring. And yeah, pretty much goes down in a diagonal way. So if you were ever to actually try to retract an inguinal hernia, you have to move laterally to push it out this way. And this is also why, like, okay, it closes up really well normally, right? But there's a defect that causes it to stay open during adulthood. And then that's why part of the bowel can actually come out through the inguinal canal. So this is just a way to remember what forms the inguinal canal. So the muscles form the roof of the inguinal canal on top here. The aponeuroses of those muscles form anterior wall. Then there's the ligaments in the middle, and then at the bottom, which forms the floor. And then you've got the fascia and the tendons that forms the back. Okay, this is important. So in Monash land, they love hernias, and you can kind of understand why, because in real life, they're very common. Like, I didn't think they were going to be that common, but they are. And apparently a lot of people walking around with hernias because they're not often life-threatening, right? So people walk around for years with just a random hernia. Okay, so the only problem is, so it only becomes an issue when there's swelling. There is like skin changes, and the bowel doesn't seem to be retractable or reducible. Okay, so if it's irreducible, it is now incarcerated, which can then turn into a strangulated hernia, and that's really bad, because then that's when it's been incarcerated for so long, right, and stuck outside, that it started to lose its blood flow and then die. Okay, so ischemic bowel, that is a life-threatening thing, because you can get, like, septic, and obviously you have lots of problems from food not being able to go through. So really, really remember this, I think, okay, because this is how I remembered it. Okay, so DM is direct inguinal hernias are the ones that go medial. So they exit the abdominal cavity, medial to the inferior epigastric vessels. So what are these? Why are they important? Well, we'll go through them later, but basically think of the Hasselbalch's triangle. This is a weakening in the anterior abdominal wall. So Hasselbalch's triangle is weak because it's literally no muscle. Like, there's no, like, you're pretty much only got like the transversalis fascia there. So it's like, yeah, we really failed in like evolution, and we left out this like part of the abdominal wall that's just not protected. So this is the Hasselbalch's triangle. Now, it's really important that you need to, like, you remember the borders of the Hasselbalch's triangle, because they like testing on that for some reason. And that's where, like, for example, people like who do heavy lifting, or like weightlifters, that's where it often comes out through the abdominal wall. Okay. So remember, it's bordered by basically the epigastric vessels, the inferior epigastric vessels, the rectus abdominis muscle, and then the inguinal canal at the bottom, or the inguinal ligament, more likely. Yeah. And then indirect is the one that actually goes through the inguinal canal. So direct goes directly through the abdominal wall. Indirect goes in a indirect way. So it goes and does a little bit of a snake through first before it goes out. So that's how I remember it. This is pretty much what you really, really need to remember, because they really ask you a lot about that. Cool. So that's the indirect is when it goes through, and it goes all the way into the scrotum. So oftentimes you'll see this enlarged scrotum and you need to push it back up through the inguinal canal now in like more of a year 3 setting, if you have to test it for a cough impulse, that's how the cough impulse is how you test whether or not it is a hernia or like some sort of like cancer lump instead, right? So you want to try to retract it. So you want to reduce it. So you want to push that lump up, and then you want to hold it where it came out. And then you tell you make sure the patient is lying down when you do that. And then hold that part where it came out, tell the patient to cough. Now, if they cough really loudly and the lump comes back out a little bit, or it presses against your finger, then you know it's a hernia. So positive cough impulse is a hernia. Okay, that's next. Okay, femoral hernias, they don't test much, but just know that it happens more in women. That's more of a like real life thing. But in Monash land, just know that it's navel. Okay, just know that this is where the into the femoral canal, that's where it comes out, and know where like it comes out underneath the inguinal ligament. So that's how you would differentiate between like a direct inguinal hernia versus like a femoral hernia, right? A femoral hernia is usually a lot lower down and it comes out like somewhere here, okay, underneath. Cool. All right, so this is, pretend we're like a baby sitting inside the like someone's abdomen and we're looking out. That's how this view is. Okay, so this is where the belly button would be, right? And then we're looking outwards and we're just facing the same way that the person is facing. So these are the really important ligaments to learn. And most importantly is the lateral umbilical folds. That's because they have the inferior epigastric vessels, which are the big vessels, you don't want to harm them. So yeah, just learn that the lateral umbilical folds have those, then kind of just know of, actually no, they do test you on this as well. The medial umbilical ligament, they cover the what used to be like the umbilical artery, and then the middle one, the median, is the obliterated urachus, basically. So the embryonic umbilical fold. Don't know why I said that, but yeah, basically a little bit obliterated urachus. Okay, cool. And then next. So another better view of this. Posterior. Right. I learned this in detail, but it never really came up. I don't remember it. So just learn what these are, like know where the muscles are in the back. So we're looking at like basically the lumbar region right now, and then we've got the kidneys here. Okay, you don't need to know what surrounds the kidney, that's too much, but you do need to know that these are what muscles these are, what muscle this one is, what muscle this one is, and this one is. Those are the important ones. So just remember what they are. And if you want to be like extra, you can learn the fascia as well. Okay, diaphragm. Okay, this is important. So they want you to know, that you know what goes through each of these like holes in the diaphragm. Okay, so this one, IVC. Okay, this one is the vena cava. Oh shit, no, this one's the vena cava. This one's the esophagus. Okay, so IVC, the way I remember it's T8 is vena cava. So vena cava is 8 letters. So 8 letters is T8. Okay, but also it goes, the right phrenic nerve also goes through that. And then T10, esophagus with an O is spelled with 10 letters. So therefore it is T10. And then this one, aortic hiatus, 12 letters. So T12. Okay. Know what goes through, memorize this. Okay. And then these are the ligaments. These are actually surprisingly like high yield for some reason. But median ligament, arcuate ligaments, these are basically formed by the right and the left crude of the diaphragm. So here, and yeah, this is basically what forms the aortic hiatus as well. The medial arcuate ligament is this one here, and that is the thickening of the psoas major fascia. Okay, and then here is the thickening of the fascia on top of quadratus lumborum. So pretty high yield. So just remember lateral, medial, median, and what they are on top of, or what they are comprised of. Okay, cool. Landmarks. Okay, pretty high yield yet again. Pretty easy to remember what these names are for, but sometimes you need to pay extra attention to pouch of Douglas and pouch of Morrison, right? They're like, you can't just figure out what pouches they are just by the names. So retrovesical, vesical meaning bladder. So rectum, bladder, between the rectum and the bladder. And just remember, there's a uterus in women. So this isn't only exists in men, okay? And in men, when they stand up, it's the lowest point. So that's where blood or whatever fluids they have in their abdominal cavity will pool when they're standing up. And then in women, this is called the pouch of Douglas. However, wait, did I write something down? Oh, okay. This is the lowest point in women when they are erect. And I think I put this picture and it covered it. So instead of the bladder in women, there's a uterus as well, right? So this is the point where the fluids pool in women. So the pouch of Douglas, pretty high yield. Hepatorenal pouch / pouch of Morrison, on the other hand, is not on the bottom, it's on the top. Okay, so here it is in the middle between the liver and the right kidney. So think this is anterior, this is posterior, okay? And it is just like in the space between the liver and the kidney. And that is where the liquid will pool when the person is lying down, okay? Cool. So here, just this is the process called cholecentesis. So basically when there is a lot of fluid or blood kind of pooling in that pouch of Douglas in women, right? Then what happens is they kind of, ouch. They pull open the vagina, they put a needle through and cut through the vaginal wall. And then that's where the pouch of Douglas is. So yeah, just a little extra knowledge. Transpiler Plane. I freaking hated this. I never learned this. So, and I don't think it was that high yield, but please correct me if I'm wrong, David. Just like this kind of like arbitrary line, like plane in the body, called the transpiler plane. And it's called transpiler because it's across the pylorus of the stomach. Okay. So the beginning of the stomach. Yeah, just find a way to remember what's there. But if you like are stuck, you can kind of figure out by just thinking as well. Yeah, so here's trans-P, which is one way to remember it. And there's other ways and the mnemonics online if you want to search them up as well. But I don't want to learn that. I don't want to.
There's only like 3 you really need to know. So if you know Kylie might need to help me, but if you need to know the hilum, like the hilum of the kidneys, hilum of the spleen, and termination of the spinal cord are at L1, you'll probably be fine.
Okay, yeah.
What do you think that's?
For spleen, it goes from rib 9 to 11. They had a question on that, I think. So the spleen is behind rib 9 to 11, and it's also where the hilum of the spleen is. But yeah, it's not much. It's not much. And remember, it's L1. So like, if you think of a lumbar puncture that is past L1, it will be L3. It's a lumbar puncture. That's where like they put like the needles, and because we don't want to hit the spinal cord, right? And that's where they'll put the needle to do a lumbar puncture. And lumbar puncture, if you don't know, just is to collect like cerebral spinal fluid. Yeah, cool. You'll learn about it later. Okay. This I learned pretty last minute last year, because I just completely missed it. So I just chucked it in here because I feel like, oh, you shouldn't do the same mistake as I did. Just learn like, oh, right hepatic duct, left hepatic duct. This part is the common hepatic duct. This part that goes to the cystic part. Okay, so this is the gallbladder. If you hear cyst, it just means gallbladder. Not cyst, but like any word starting with cyst is gallbladder. Okay, so cystic duct belongs to the gallbladder. This is the common hepatic duct because it's only come from the liver. And then coming down, because everything's joined up, now it's called common bile duct. And then we've also got this pancreatic duct coming in as well. Know that this comes in D2, so ampulla ovata comes in and it empties out the bile in the major papilla of the D2, which means the second portion of the duodenum. There's 3 portions. Yeah, and this is where sphincter of Oddi is as well. And that's what controls pretty much the bile excretion as well. Okay, cool. Oh, yay, we've gone to embryology. I hate this. Embryology. So everything just looks like a blob to me. So that's why I'm just like always had trouble with this. But basically this blob here is when we cut like we slice the embryo this way and we're looking down on it. Okay, so this is the cord. Okay, the spinal cord later, and then this is the gut tube. So basically what happens is lateral folding is like, think of like this, like yeah, your sides are folding down, and what happens is it engulfs a little bit of like what was the yolk sac to form the gut tube. Okay, so the sides of the blob encase a bit of the yolk sac to turn it in. Yeah, that's exactly what I just said. Okay, cool. Yeah, and so just to erase any confusion, because I was very confused last year, the yolk sac is not the same as the placenta. It doesn't turn into the placenta, but it's basically like a temporary placenta. So it gives nutrients at the beginning, like the first trimester, so like 6 weeks or so, and then that's when the placenta is forming. So the placenta is like taking its time to form, but then once the placenta is formed, it kind of takes over the role for nutrients. And yet the placenta will form around pretty much and become the connection between the fetus and the mother. Okay. This one, a cephalic and caudal folding. Basically, brain is growing, brain is heavy, big brain, head weighs down, and then it goes, and this is the head, for instance. Okay, this is the butt, so it kind of folds down, and then obviously this the fetus thingy looks more curved and looks more like a jelly bean now. So this is a different one. And so the lateral was the sides, but this time cephalic and caudal means head and tail. Okay, so head tail folding. So in this case, this is when the gut tube elongates. Yeah, cool. This is important. So foregut is anything from the mouth all the way to D2, which is where the bile gets excreted, comes out from the common bile duct. Okay, and that all the way to there, that's called foregut. Okay, any pain, any problems in the foregut will usually manifest as an epigastric pain. So that means it's right in the middle of underneath the sternum and then between the ribs, right? So that's the epigastric region. So that will be things like GORD and esophageal problems, okay? Peptic ulcer problems, yeah. So epigastric region. And then the arterial supply is from the celiac trunk. And then the midgut is from that point onwards all the way to the splenic flexure, which is basically the part of the colon that bends on the right side where the spleen is. Okay, so that's pretty much the proximal 2/3 of the colon. And then the pain will radiate to like the umbilical region, so to your belly button, and then it's supplied by the SMA, the superior mesenteric artery. And then hindgut, that's basically from that splenic flexure all the way to the pectinate line, which is where the part in the rectum that kind of goes from like visceral to somatic sensory neurovasculature. English. Okay, so the pain there will go to the suprapubic region, which is just on top of your bladder. Okay, and it's supplied by the IMA, which is the inferior mesenteric artery. Foregut. Okay.
Kylie, should we
Yeah.
maybe?
What?
Can
What?
you mind going back 2 slides?
Yep. Yep.
Should we
2
ask
slides.
them one more? Back one more. Wait,
Yeah.
forwards one more. Forwards one more. Forwards.
What'd you say?
Can you go to the slide where you describe the foregut, midgut, and hindgut?
Oh, okay.
Yeah.
This one.
Yeah. Should we ask them which of these arterial supplies originates in the transpyloric plane? Do you remember?
Bro. Anyone remember?
You don't have to be nervous. We don't care.
Yeah.
SMA. Beautiful. Yeah, so that's a superior mesenteric artery. So L1 is the transpyloric plane. It's a good job.
Well done. Okay. Next. Foregut development. Okay, awesome. It's just a bunch of things rotating in foregut. So just think, oh, liver massive, oh, big boy. So it starts to press on so initially it's like a big tube, right? And then there's like random swellings on that tube, the gut tube. And now this big swelling is actually growing upwards and outwards. So it's pressing on all the other swellings. And this liver basically will grow upwards into the what is going to become the diaphragm. What is it called? The septum transversum. And that's why it causes that bare liver, bare area of the liver, by the way, because it kind of just splits in like from like ventral and then dorsal, kind of splits. And so there's this one part where it's just not covered by mesenteric. Okay, cool. So basically the stomach, it gets pushed away from the liver, by the liver. And then it, instead of facing forward, it starts to turn clockwise. So it starts like what was at the front starts to face the right side of the body. So we pretend this is the front. Okay. So the front kind of turns around this way clockwise, and then it's now kind of just facing the liver. Okay. And then the back gets pulled out from behind. The back grows a lot faster. And as it gets pulled out from behind, it takes part of the mesentery with it as well. So now we've got this like greater omentum starting to form. Okay. So that's how that mesentery comes out. And we get that typical J-shaped stomach. Okay. So cool. And then the liver keeps going up. So that's what I just said. Moving on. Pancreas. This is important to know. The pancreas rotates. So initially we start off with this ventral pancreatic bud here. We've got the gallbladder here, dorsal pancreatic bud. Okay, moving on. So it starts growing. This ventral bud actually grows and grows and grows, and it gets pushed behind. It goes and rotates and rotates and rotates, and until it meets this dorsal bud on the other side. And then they should kind of fuse. And the vascular, the ducts also kind of fuse. And that's what a pancreas will end up as, just one big pancreas on one side. However, there are problems sometimes. Okay, so obviously this could either not fuse with the other one and cause like this bifid pancreas later, or it could, this is, I don't know what this is, bifid ventral pancreas bud. You don't need to know this very well, by the way. Obviously why I don't know it. But basically, yeah, so either it doesn't move over, or it kind of does, but then it tries to take a shortcut and just wraps around, and that's no goodie. And then it turns into this annular pancreas, basically, where the pancreas goes around this gut tube. And so that's a problem, because then obviously food can't go down further than that part of the duodenum. And then yeah, you have vomiting and everything. So that usually comes out like in children, because if you're an adult, like how are you alive? So as a child, it would manifest in a child usually. Okay. All right, just know, especially the retroperitoneal things. So here's the like what organs are intraperitoneal, what's retro, what's secondarily retro. I think because they like quiz you a lot on this, just like the professors like to ask. But there are some that you need to kind of know, right? Like the kidneys. Oh, the kidneys are definitely retroperitoneal, always have been, and parts of the duodenum, parts of the colon as well. So just look at this, memorize it. Okay. Amenta. Okay, this really fucked me up last year. Like I just did not get around to understanding it until the end of last year. So basically, like I said, like the liver basically separates the ventral and dorsal mesogastrium and then causes that like bare area, right? And as it grows, right, it kind of pushes everything, rotates everything. So like we said, the stomach rotates, spleen also moves, and then pancreas also rotates. All of that's caused by like the liver growing, okay? And then as it gets rotated, it pulls out these sacs, pulls out these like mesentery, okay? And it forms these ligaments later on. So just I drew a drawing, didn't put it in. Basically know that there's a lesser sac and a greater sac, and they're formed by basically like they're like bags, like areas where things can go inside the abdominal cavity that is formed by these mesentery. So the lesser sac is that area behind the stomach. So the stomach is like, there's basically, it's not like floating in your abdominal cavity, right? It's got this this mesentery that's holding it up, and the mesentery that's like underneath it and connected. The greater omentum is connected to the stomach and the transverse colon, right? So yeah, so the stomach's not just floating, it's connected to a lot of things. And then, but underneath it, so behind it, is the lesser sac. So the behind it, you can go through this hole called the epiploic foramen of Winslow, and if you go in there, that's where the lesser sac is. I'll have a picture of it later. Let's see if I do have it here. Yeah, so here the lesser sac. Okay, so this is the liver here. This is the stomach. This is the lesser mesentery, lesser omentum, and then behind that, this where the arrow is pointing in this little hole, that's called the epiploic foramen. And if you put your fingers in through that hole, then you would get to the lesser sac. Okay, so this is the lesser sac. It's not formed yet. This hang on. No, you can't really see it, but this is the lesser sac. Okay, in behind the stomach. All right, moving back. So the greater sac is just everything else on the outside. Okay. Ventral mesentery. It's formed by the falciform. It forms the falciform ligament. Don't really have it here, but it's basically connected with the liver to the abdominal wall, and then the lesser omentum is formed by the hepatogastric ligament and the hepatoduodenal ligaments. So as you can kind of guess, liver, stomach, ligament. So goes from the liver to the stomach, and it holds the stomach in place. This ligament goes from the liver to the duodenum, which is very close, and also holds, it's tiny, this ligament, and it holds the duodenum in place. And that's where we do this. We'll talk about it later, but this is where it is. Okay, so this is where the gastro ligament would be here, and then the hepatoduodenal is here. Okay, so they're merged together here. Okay, and then the dorsal mesentery forms the greater omentum. So we've got the gastrocolic, which hangs down in front of the stomach and then hangs over the transverse colon. So it looks like an apron in a real person, like it's this flap of fat and it's kind of weird, but that's the gastrocolic ligament. It's very big. And then the gastrosplenic and the splenorenal, you can guess from the names. So these are the ligaments that you kind of need to pay a bit more attention to because they actually contain arteries and or arteries are underneath it. And if you were to have a hemorrhage, you need to know where to look for it, right? And also for some surgeries, you can clamp down. So for a hepatoduodenal ligament, that is actually where the portal triad is. So you remember the portal triad is the duct and the artery and the vein. So you do this Pringle maneuver, which is where you just clamp down on it, clamp down on the duodenal ligament, the hepatoduodenal ligament, and that's to stop bleeding. Okay. Hepatogastric ligament is where the left and right gastric arteries are. Gastrosplenic ligament, where the short gastric arteries and the left gastroepiploic artery is, and the splenorenal ligament, splenic artery. Okay. Cool. Just memorize this, but it is it comes up in one question every year, kind of. So just memorize it. Midgut rotation. Cool. So we're down to the midgut now. Basically, we started with a cranial limb and then a caudal limb. And this is the SMA, so the superior mesenteric artery. And this SMA acts as the axis. So it rotates around the SMA. So as it rotates, so this bottom limb goes up and goes to the top. You think this cecal bud is where the cecum is. That's basically the transition point between the small and the large intestines, right? So use this as kind of a way to orient yourself, right? So you twist it and then little cecum over here, right? And then cecum is forming over here still. And then this pink one, so caudal limb, is going to be the large colon. This purple one is the small colon, right? So it grows really, really quickly and it just kind of cramps up the space. This one keeps turning. And later it will grow more so that it kind of rests on the right side. Okay. So the way I learned this was just to keep referring to the adult anatomy and think, how did this end up where it should be in the adult, right? So that's how you make sense of it. Cool. I wrote the steps here. Another thing to note is that the ligaments are there to keep them in place. So as it's rotating, you think, you don't want it to rotate flop everywhere. You want it to kind of stay in the midgut region. So the ligaments, there's two that you need to know of. There's the superior retention band, which is basically, I don't have a picture of it, do I? Oh, no. Okay, well, superior retention band is over here, okay, on the cranial limb. And it's called the ligament of Treitz. And then it's basically where it's attached to the part of the diaphragm that creates the esophageal opening. And then it goes all the way and attached down to your duodenum. Okay, so this cranial limb here, it should be pretty much coming from here. And then the caudal limb, or the one that's attached to the caudal limb, is called the inferior retention band, or the phrenicocholic ligament. And that is where it goes from the diaphragm again to the splenic flexure. So it just keeps it in place so that it just rotates together. Okay. Cool. And then this is the cecum. This is the appendix. Okay. So this is the caudal limb, and it's starting to grow, starting to flop to the right side. This keeps growing really quickly, and it just kind of congests and moves on to the left side. Okay. So this is the small intestine. This is the large one. So then as this happens, there needs to be obliteration of the vitelline duct. So the vitelline duct is basically where the fetus gets its food and makes its poop, or it kind of just transfers its waste out this way. So if it doesn't obliterate, what can happen is you get this Meckel's diverticulum, which is basically this like this outpouching of the gut, and it causes problems when you're an adult. Usually you can have diverticulitis, which is basically inflammation of that diverticulum, and don't mix it up with appendicitis, because it really can be anywhere. It usually is in the center or on the side, lower abdomen area, and it just comes like they come with abdo pain and like vomiting, and you think, oh, haha, abdo pain and vomiting, look, it's appendicitis. But no, it can be diverticulitis as well. Cool. And then ascending colon, so you can't see it really right now, but it's basically like here, and it's forming as it grows, and it as this grows, it cools downwards as well, and the ascending colon descends. Okay, cool.
Kylie, just quickly, if we go
Oh
back,
yes.
do you think, can anyone tell us what this is?
What?
Do you see my annotation? What is appendix? Great. Yeah, that's really good. So that's the appendix.
Yeah, and the cecum is just right above it. All right. Hindgut development. I love this because every time I think of it, I just think of birds, because one professor talked about it, like talking about mixing urine and feces, and I'm like, yes, birds. Okay. Anyway, so you've got this urorectal septum coming down. It's just basically a bunch of epithelium, and it just comes down like a wave, just whoosh, and then it grows out, and then this is the cloaca, by the way, and it goes and it separates the cloaca into two divisions, and those two divisions form your bladder and your rectum. Okay, that's pretty much it. So it grows out, and then this, by the way, is called the perineal body. The epithelium at the beginning of the wave, it's called the perineal body. Anyway, it divides the pouch into anterior pouch and posterior, and like I said, yeah, bladder and rectum. And then if it doesn't divide properly, obviously you'll have problems forming proper pee and proper poo. Will just be mixed together. And then this next thing is basically like when it kind of pinches and it kind of meets the outside, you've got the ectoderm coming invaginating, so coming inside to meet it. And then the endoderm is obviously the gut. And that's what forms the pectinate line. Okay, so the pectinate line is the section where the ectoderm and the endoderm meet. So moving on. Yeah, so this is the pectinate line, and that people always say it looks like teeth, but obviously it just looks like anus. So I don't know how much teeth like it can be, but yes, it just looks like grooves. So pectinate line basically delineates the difference between like a lot of things, right? So the epithelium on the outside will be similar to the epithelium on the skin, like of your butt, right? So it's going to be squamous, a stratified squamous, okay? And then inside will be the same as your gut tube, so columnar. Arterial supply is also different, superior rectal artery and then inferior rectal artery, right? And then we've got the venous drainage. We've basically the above it will be superior rectal vein that goes to the portal system, whereas on the outside, it's the inferior rectal vein, so exactly the same as the arteries, except it goes to the IVC. So that's the normal blood system. Oh my god, I forgot what it's called. The systemic blood system. So portal versus systemic. So that's another. I'll talk about it later, but like it's a site in the body where the portal system and the systemic system meet. And so if you don't remember, like the portal system is the blood that goes to the liver to get like, detoxified and stuff like that. So that's portal, whereas the systemic is like the rest of the body. Yeah. Okay. Lymphatic drainage, internal iliac nodes versus inguinal nodes. Okay. That's just something you have to memorize. And then innervation, they talk about like hemorrhoids often. So hemorrhoids inside, like deep inside, where above the pectinate line will not hurt as much as the ones outside because of the different innervation. So we've got a visceral innervation inside. So all it can feel is stretch, right? All you will feel is stretch if you have hemorrhoids inside. Whereas on the outside, you'll feel pain and other somatic. So pain, touch, temperature. Okay, so that's pretty important. Just remember that. Celiac trunk, T12. Practice drawing this, practice this anatomy. You kind of need to know like exactly which, like you just know this very well. Know which arteries are which, know which arteries supply what. Okay. Don't need to go in too much detail, but like learn everything that is like on this slide at least. Okay. They do love to ask things about the spleen, the splenic artery, and all of that shit. So learn that well. And also know like the common hepatic artery and stuff like that. Okay, I'll go into more depth. So the splenic artery is inside the splenorenal ligament. And if there is an ulcer, so if you have PUD, peptic ulcer disease, and you've got an ulcer at the back of your stomach in the posterior wall, what happens is that ulcer can erode the wall. Okay, so it can eat through the wall. And then, guess what's there? The splenic artery. So if there is perforation of an ulcer, right, it can affect that blood supply, and then you can start bleeding from the splenic artery. So again, they will ask a question about surgery or something, or a peptic ulcer, and you need to know what artery is affected. Okay, short gastric artery, just fundus, not much to do with that. Common hepatic artery is then split into proper hepatic artery and gastroduodenal artery. So gastroduodenal, and then the common. Okay. So basically, the proper hepatic artery will then split again. The right hepatic artery, so split into right and left. The right hepatic artery is in this one, Carlos triangle. This is surgically significant. They ask about it in like tutes, but I don't remember them asking about it in exams. So I don't remember how high yield it is, but they do kind of want you to know about it. So the Carlos triangle is just significant in like cholecystectomies, when you cut out the gallbladder, right? You need to know where the arteries are. And this is formed by the liver. It's formed by the common hepatic duct, and it's also formed by the cystic duct. So that's basically the triangle. And then inside it, you've got all these arteries. So, yep, inside the Carlos triangle, there's the right hepatic artery, which also splits into the cystic artery as well. Okay, and then gastroduodenal artery. This one is more high yield than anything else. Okay, it basically, if there is an ulcer here instead in the duodenal part of the GIT, then what it can do is it can erode again the wall of the duodenum, and then it will affect the gastroduodenal artery, which is right behind it. Okay, so just remember that. This is not as important. Moving on. Cool. Learn the anatomy of SMA and IMA, unfortunately. So you need to know what they're called. Don't need to know too much about it, just what they're called. And what, like, so if I were to cover all of these labels, you need to be able to label all of this, basically. Now, middle colic artery actually is this one here. Okay, so this is more significant because it actually goes and attaches with the marginal artery. And in the between this area where the splenic flexure, that's where it's called a watershed area. So that's where usually if you are in a perfusive state, so for example, you're very, very anemic, or you've got some other blood problem, you're running out of blood or something, whatever, that part can start to become ischemic, because all of this gut is primarily supplied by this artery, right? These arteries. And then all of this gut is, oh yeah, I've got my own supply. However, this part, okay, the blood will not reach this part as if you have like very little blood, this blood will not travel as far. This blood will also not travel as far. This part, because it's got no designated blood supply, it will actually be the first to die. Okay, so this is the watershed area. Just know that. Okay, and then the nutcracker syndrome we talked about before. Basically, the SMA, as it comes out, it compresses on the. I think this might be it actually. Yeah, this gray thing here. So this SMA, as it comes out, it goes on top of the left renal vein and then causes nutcracker syndrome, which manifests as a testicular problem as well. Okay, this is IMA, the inferior mesenteric artery. Learn the what part of the abdominal, like what level of the abdominal aorta it comes down as well. So L3, this one was L1, this one was T12. Okay, so just remember those because that's important. So it kind of takes, so it connects with the SMA. So this part, the yellow part is the SMA, but this green part is now IMA. Okay, so the connection between SMA and IMA is the watershed area. So yeah, just don't need to know much about it, just know the names of these arteries. Cool. And I said this before, but superior rectal artery in itself doesn't have much significance, but the vein has more significance. So the superior rectal vein is a site of portal systemic anastomosis. So that's basically when the portal system and the systemic system join together. And it's important when it comes to portal hypertension. Like you can have varicoses, and but you can also have do I talk about it more? No, I don't. When there's portal hypertension, blood won't actually go from into the portal system because there's too much like pressure there. So, but you'll still have like blood flowing everywhere. It's just that there's a bit of a danger in that blood isn't going to the liver, so it's not being detoxified. Okay, but don't need to know much about it. Just a bit of extra information. Learn this. It's not too high yield, but learn it. Especially the kidneys, and also the bifurcation of the common iliac, the abdominal aorta into the common iliacs. Okay, this is what I was talking about before, so I do mention it a bit more. This is the portal system. Do learn this. I think they do ask about it like once or twice. And then these are the parts of the body where there is portosystemic anastomosis. This is not important, but it's just a bit of extra info if you want to know. And this lower esophagus is important later on in like year 3. This is what I was talking about: superior rectal veins and inferior and middle rectal veins. Okay, this is what I was talking about before. But all the other ones, just don't bother. Don't bother looking at it. But it's just extra information if you want. Okay, cool. Autonomic innervation. So it's kind of important, but what's more important is that you understand this process. Okay, so this is the most high yield part. The systemic, the sympathetic innervation basically goes and either synapses with the prevertebral or para-aortic ganglia, or it will go spinal cord. Then it goes into the white rami communicans, and then to the elevator, as she mentions, and then the sympathetic trunk, it goes and synapses at the same level, or it will go up and down the up or down the elevator, and it will synapse where it leaves, and then it goes through the gray rami communicans to the splenic nerve, and then prevertebral ganglia. So yeah, just memorize these. So 5 to 9, T5 to 9 goes to greater, goes to celiac, and then supplies the foregut. I can't be bothered reading this out, but like learn this because this is pretty important. And I forgot to put a red flag, but like it's more of a high yield thing, I reckon. Yeah. And then this is not the same as the rest. This is T12 and it supplies the kidneys. Okay. The least splenic nerve supplies the kidneys. Okay. Cool. And the next one is parasympathetic. Just remember brainstem and S2 to 4. Brainstem goes to vagus to foregut, S2 to 4 pelvic splenic nerves to midgut to hindgut. And then this is just visceral versus somatic pain. And we did touch on it just before with the hemorrhoids, but visceral pain is usually very vague, very like poorly localized, and it will be like more diffuse and dull. And don't need to know too much about this. But then somatic pain is basically very like well localized. You know exactly what point it hurts. And it's things that are usually more superficial. And it's like peritoneum, for instance. Okay. All right. Am I done? Yes, I'm done. All right. So do you guys have any questions? You can chuck it into my DMs if you like.
That was really good, Kylie. Very impressed.
Speaking a lot. Okay, if there's no questions, and I'll pass it on to Andrew, who will cover physiology. Is Andrew here yet?
He's not here yet, but there are only 4 slides for Andrew, so do stick around for that. I've texted him, he's coming. Yeah, Kylie, that was really good.
Oh, thank you.
You knew everything. And Andrew is here. Thanks so much, Kylie.
No worries. Should I stop sharing then?
Yeah.
Okay.
Hey, Andrew.
Hello.
How are you?
Good, good. How are you?
We're good. We just did the whole anatomy of the GIT.
Yeah, you guys have a lot of slides, very long.
It was
Bit of a
sick though.
trek.
Kylie did all the embryology as well, which I haven't seen anyone do before.
Embryology is not my favorite, I'm not gonna lie.
That was solid. Yeah. So thanks so much, Kylie. If you want to leave, that's all right.
Okay, thank you. Gonna take
Thank
my
you.
leave.
Bye.
Bye-bye.
Okay, Andrew. So yeah,
Okay.
whenever you're ready, just to share.
Sure.
Yeah.
All right. So I'll just briefly take you guys through physiology. Physiology is very short for this week, or at least this first lecture that you guys have. You'll get a bit more on gut physiology next week, but this part is very short. It's short and sweet, so not much longer to go, only a few more slides. So we'll talk about gut motility. Gut motility is basically where your intestines and your gastrointestinal tract is pushing through your gut. So there's 2 sort of contractions that your gut undergoes. So they can have something called longitudinal contractions. So that's occurring in the direction of the gut tube. So your muscle fibers will actually be aligned in the direction of the gut tube, and then they'll contract. And these longitudinal contractions, because they're occurring in the direction of gut tube, they will cause it to shorten. And you also have circular contractions. So instead of being oriented longitudinally, these muscle fibers are actually orientated circularly around the gut tube itself. So you can imagine that when it's contracting, it will actually cause constriction. So you can see on the diagram on the right. So let's pretend that's the esophagus, which we'll talk about on the next slide. You can see that where I've labeled it, it's constricting behind the food. So it's making sure that the food can't go back up. And then it's also shortening below it. And all of this helps to push the food down. So yeah, that's basically it. So with the esophagus especially, so that just moves the food from your throat or the pharynx down to your stomach. And you actually have stretch receptors inside the esophagus itself, and that's what's triggering the contractions. If you have the same videos as we did with Julia Coate, she explains it quite well. And she does also mention that even if you take a bit of esophagus by itself, you don't actually need the brain or anything. The stretch receptors, even if you just touch the esophagus, the stretch receptors will trigger the contractions. And then just a quick note about some of the nerves you might find in the gut. So you'll have some sensory nerves in the gut. These can be chemoreceptors or the stretch receptors we just mentioned. If they're chemoreceptors, for example, in the small intestine, you will get a release of bile. So you might know about that. You get stomach acid to digest your food in the stomach. And as it goes into the duodenum, the small intestines, you get some bile released. And that actually neutralizes the stomach acid and it will increase the pH. So you can actually get some chemoreceptors there that detect the increasing pH from the bile, and it will tell the small intestine to start undergoing the peristaltic contractions that we just mentioned. And then you can also have stretch receptors, which you talked about. And other than the esophagus, you also have stretch receptors in other places in the gut. So that includes this stomach. If you have stretch receptors in the stomach, that actually tells the small intestines to undergo something called segmenting contractions. So don't worry about segmenting contractions right now. You will see that probably next week in the next video. you have a few videos on gut motility. But yeah, just be aware that there's chemoreceptors and there's stretch receptors. And there's also autonomic nerve fibers. And these predominantly just control the glands and your smooth muscles. In general, parasympathetic nerves increase gut motility. So there's contractions and gut secretion, and that will be acetylcholine acting on your muscarinic receptors. And your sympathetic nerves will reduce motility and gland secretion. So that might be noradrenaline acting on your adrenoceptors. You also have sphincters, which we'll talk about a little bit in a little bit later. So sympathetic fibers will keep these sphincters closed, and your parasympathetic and something called enteric nerves, which we'll mention soon, again, open sphincters. And apart from that, you also have some somatic nerves that just control skeletal muscles. So these are voluntary, whereas, as you know, your autonomic nerves are involuntary. So your enteric nerve fibers, they're quite similar to your autonomic nerve fibers in that they control your smooth muscle and they also control your glands. So things like secretion and motility, but the enteric nerve fibers are actually intrinsic to the gut. So they're sort of, they're connected to your central nervous system and your peripheral nervous system, but they actually belong to the gut itself. And we'll talk a little bit more about that. So the intrinsic nervous system in the gut is the enteric nervous system. So even if you had some damage and say, you know, somehow you just didn't get any innervation from your central nervous system to your gut, the enteric nervous system is actually all located within the gut itself. And so even if you had like damage, for example, your gut would still be able to contract and all of that. So there's two intrinsic nerve plexuses within this enteric nervous system. You have your myenteric plexus, which is located in the smooth muscle layers, and these control the gut motility. And then you also have a submucosal plexus, which is located in the submucosa. So you can see that in the top right picture here, you have your smooth muscle on the outside of your myenteric plexus, and then you have your submucosal layer, which also has a submucosal plexus. And within the submucosal plexus, these nerve fibers will control your glands. So just like your autonomic nervous system, these fibers can either be excitatory, so they might trigger secretions, they might trigger gut motility, or they can inhibit them. So generally, same as parasympathetics, they use acetylcholine for motility and secretion, but they will use nitric oxide to relax the smooth muscle when they're trying to inhibit the smooth muscle contractions. And you can see this diagram here. So you might have some stretch receptors in the mucosa here, the epithelium of the gut tube. You might also have some chemoreceptors. They will send up information up to your central nervous system. The central nervous system can then affect the gut by the sympathetics and parasympathetics, which might terminate directly onto the gut itself, but it will also connect to the myenteric plexus and the submucosal plexus itself. So you do get the sympathetic and the parasympathetic system actually regulating the enteric nervous system as well. And you can see that the stretch receptors also feed directly onto the enteric system itself rather than going to the central nervous system. But that's just about as much as you need to know. You just kind of know that this exists and they regulate the gut as well. And there's some interplay between the parasympathetic, or the autonomic nervous system and the enteric nervous system. And then finally, we'll just briefly mention sphincters. So sphincters are basically where you have thick and smooth or skeletal muscles in the gastrointestinal tract. So when they constrict, they will block off the tube or the lumen. And that's just to help prevent backflow of food and regulate the movement of food. So most of these sphincters are all smooth muscles, which means they're under autonomic control and you can't actually control them voluntarily. Only your upper esophageal sphincter, which is here, and your external anal sphincter, which is the last one down there, is voluntary because they're skeletal muscle sphincters. So there's quite a few. You don't need to know too much about them really. You just need to know that they exist. So you have your upper esophageal, your lower esophageal, and then your pyloric sphincter, your sphincter of Oddi, which is actually a sphincter between like your bile ducts and your pancreas. So This is what controls like the release of bile and stuff into the duodenum. And then you also have your ileocecal sphincter, which is between the ileum, the small intestine, and the cecum, which is part of the large intestines. And then you also have your anal sphincters. And that's honestly pretty much all you need to know. They just exist. So for example, with your lower esophageal sphincter, if you're eating food, this will keep the food inside your stomach while it's churning, and it won't let any stomach acid or food back up into the esophagus. However, if, for example, your sphincter is damaged or it's not that strong, that's where you might get some reflux back into your esophagus, and this is why people get heartburn and stuff. And yeah, that's about it. That's all for physiology this week. So quite short and sweet and not too hard.
Thanks so much, Andrew. I'll stop recording.